it's interesting, I've only been here since August, but the number of ankle injuries that I saw seemed like every single day it was like 5, 10 kids, adults, everybody who had an ankle seemed to be injuring it around here, and I'm not sure why. I think it's because it's a very active community, and it's a very commonly injured, part of your body and region. So I'm going to try to go through this, and essentially what we're going to talk about is what are some of the terms, what's the classification, how do you prevent it, how do you treat it, do you need surgery, do you not need surgery, all those things. So what are the basic categories? Can everybody see over here? Am I blocking you? You guys okay? So contusions, sprains, strains, and fractures. And my favorite thing, I did my basic orthopedic residency in Boston, at Boston University, and so people would always want to know when they came and it got destroyed by a car accident or something, is it fractured or is it broke? And I said, well, which one do you want it to be? Because it means the same thing. It's kind of, there's a lot of terms that are confusing with ankle injury. So we'll go over those. So what's a strain versus a sprain? Well, essentially, we'll go over the first one, strain first. It's basically what happens at the location where the tendon is attached to the muscle, at the musculocutaneous junction and a musculotendinous junction. So somebody said, oh, I pulled a muscle. Oftentimes you can actually pull it right in the muscle fibers, but most of the time it pulls at that junction between the muscle and the tendon itself, and that's basically a strain or a pull. What we're talking about tonight is more of the variety of the sprain, and that's essentially what happens in a ligament. And a ligament attaches two bones to each other, like the ACL, the anterior cruciate ligament. So when you basically tear that, you're tearing something between two bones. Same thing with most of, or really all of the primary structures around the ankle are ligaments, because they attach the fibula to the tibia, or the tibia to the calcaneus. I mean, so there's this very complicated, I'll show you a slide, there's got to be like, over 30 ligaments that all help to really give you support. And it's very commonly injured. Basically anything that requires running, jumping, bicycling, just go into the grocery store on ice, you can sprain your ankle. What basically happens is that you stretch it beyond what I call its comfort zone. And so, God didn't intend it to go that far, and you just stepped on it the wrong way, and it either rips or it pulls off of one of the other bones. So the big thing is, when should you go see a doctor? Now, if you're that guy and your foot is pointing the opposite way, that is a good indication that you probably should go see somebody really quickly. Hopefully that never happens with your ankle. If it does, that's a big problem. But essentially, everybody, probably most people in here have hurt your ankle to some degree, but not everybody has had to go see a surgeon or a physician or anybody. Basically, why would I go? Well, if you couldn't bear weight. That's a big problem, because you don't at that point know without an x-ray if you've broken something or if you've just really sprained the ligament. So if you can't bear weight, if you have swelling, all of a sudden your ankle's twice the size of its normal, it looks like there's a deformity, like maybe something's pointing in the wrong direction, or if it doesn't get better after a couple of days. Most of the time a very mild injury should get better in 2 to 3 days. So 85% of all ankle sprains typically are called, to use fancy words, supination and internal rotation and plantar flexion. So that's basically when you roll your ankle. And everybody, if you look at your own ankle, when you move it in like this, that basically stretches all of those lateral ligaments, and then the recoil can also affect the inside. So very common in basketball, very common in soccer, field hockey, all those types of things where you can step on another person's foot or some kind of inconsistency in the ground. You basically roll your ankle. 85% of are that type of a motion of the ankle roll. The remaining 15% are the opposite, where your ankle actually turns outwards and then you step down. And that primarily affects the inside ligaments. So there'll be a test after, so just quickly study those, and then we can ask after. But you can basically see there is a lot of ligaments supporting the ankle, including the bone in the capsule. But what are the primary ones we're going to talk about? And it's very interesting, when somebody sprains an ankle, I always press the spot that I know is going to hurt last. And people always think it's some kind of magic. Like, how'd you know that was going to be the worst spot? Well, because it's almost always this one ligament right here, called the anterior talofibular ligament. And that is the one that is most commonly strained or sprained and torn. And I always, when I examine somebody, I always start with the least painful and end right there so that they don't want to smack you right out from the exam. So these are the primary restraints. Is this one, the anterior talofibular ligament, this one called the CFL, or the calcaneofibular ligament, and the one posteriorly called the posterior talofibular ligament. Those are the ones all on the outside, and then the deltoid ligaments are the three primary constraints on the inside or medial side of your ankle. So how do you grade, or how do you, basically categorize ankle sprains? Three basic categories, which are very complicated: mild, moderate, severe. And it's essentially the degree to which the ligaments are torn or stretched. Grade 3 being the worst, grade 1 being mild. So if you look at this picture, if you just basically stretch these anterior ligaments, that one that goes between that small bone on the outside called the fibula and your heel bone called the calcaneus, if you stretch that one and you stretch the anterior one, that causes swelling, that causes pain, but it doesn't cause any instability. So you can still walk in it, but it doesn't feel right. If you tear the anterior ligament or the front ligament and you stretch the side one, that's more of a grade 2. So it's more severe because now there's tearing, not just stretching. And the most severe is when you actually completely disrupt the ligaments, either off the bony surface or right transect them in the middle. And that's an unstable ankle sprain. And that's the ones where you test people and they're just very loose. And that's very frightening to have because it really, really hurts. So what are a couple of the tests? There's two tests that I always do. One's called the tilt test, and that stresses that ligament between the fibula and the heel bone called the calcaneus. And the other test is called the anterior drawer. And all these are basically, I'm trying to see, is the joint unstable or is it stable? Because that will affect how we treat it. It also affects how long it's going to take. So you get an ankle like this, you can already see that's painful. I mean, and all of that bruising is from bleeding that happens underneath the skin, and it kind of elutes out, and it's really difficult to even examine a person right like this because it just happened so recently. So the swelling really hurts, and those ligaments are unhappy. So just an aside, people always ask me, well, Doc, do I have a high ankle sprain? And it's this mysterious diagnosis that you always hear on ESPN when they really don't know what happened to one of the football players. They'll have high ankle sprains. But I bet the vast majority really don't. But basically what that is it's a little bit of a different mechanism. Remember I talked about the 85% was the ankle roll, and this is the other 15%. And that's where these really important structures in between the two major bones, they rip and they go up, and it causes an unstable joint. And this is a serious problem, and you don't want to miss this diagnosis. And that's why we get x-rays. People always say, well, Doc, if you know it's not broken, why do you get an x-ray of my ankle? We're checking for the joint to make sure that there's not instability and you don't have one of these other injuries like a high ankle sprain or syndesmotic injury. So you hope you don't have that. But like I said, 85% of the people have a basic inversion or rolling of the ankle type of injury. So what are the principles to really getting you back functioning like what you want to do? First, you got to get down the swelling. Then you got to be able to bear weight or get back on your feet. Then you want to get back to motion because people have real difficulty moving after this injury. Then you work on the strength, and then we work on this very mysterious thing called proprioception. And people always ask, well, what the heck's proprioception? Well, you don't have to look at your feet when you walk up a flight of stairs, right? Because you know where they are in space. Your body naturally adjusts. You don't have to look at your feet when you go on an uneven surface. That's what proprioception is, the body's feedback mechanism for you to know how far you are, what surface you're stepping on, all those types of things. And this is one of the hardest things for people to get back, and it's why people have constant re-injury. So you get a 15-year-old who has an ankle sprain and they don't really work on proprioception, and then they just chronically keep injuring their ankles. And that's what we really want to talk about with our rehab. So what's the RICE protocol? That's always like the first method of defense here. Rest, ice, compression, and elevation. And remember, we're working on strengthening, range of motion, swelling, all that, trying to get it back so that then you can start really getting a higher function. This is just our Academy's recommendations, not important. So what are some of the things that help with the swelling? Well, anti-inflammatories are incredible, like Advil, Aleve, ibuprofen, all those things that you think don't really work, they actually do really work, and they're very helpful in the earlier stages for pain and swelling. But what about ankle braces? Well, ankle braces can never replace your own ankle support structures or the ligaments, but they basically can help give you support while your body's healing. So oftentimes we will start people out with really rigid ones and then gradually move them to more softer braces that give you support so that you can get back to the sports or do what you like to do. Ankle taping. So last year it was a pretty neat opportunity. I got to be with the Celtics and hang out in the locker room and help treat all the players. And you should see, it takes like an hour to tape these guys' ankles. It's unbelievable. And plus, and then their shoe size is twice as big as these. Like Shaq's, it wears a 22 without the ankle taping. So then it's like a 24 with his 2 pairs of socks. It's just a ride. But this is something that should be done by a trained athletic trainer. This is not something that you want to just whip out, go to Home Depot, get up some duct tape, tape your ankle up so that you feel stable, because it can cause a lot of problems with the skin. You can cut off the circulation, and it doesn't replace the stability of the ankle, but sometimes when people have difficulty with these things and somebody's trained to do it, it gives them that little bit of extra support that helps them get through the game, and then it has to be removed immediately after. So, what is the concept of functional rehab? So, as an orthopedic surgeon, of course, I like to operate on people because that's, what I do. But the interesting thing about ankle injuries is the vast majority of them never have to have surgery if you have proper functional rehab. And what the difference is you're rehabbing, or you're getting somebody through the injury period while they're healing, as opposed to, like, if anybody here has broken a bone, you obviously have to wait for the bone to heal before you start strengthening that body part. Not the case in ankle injuries. We start actually immediately working on rehabilitation while the ankle is healing. So it's very important to not ignore what, that you actually need to be part of rehab. So stretching, strengthening, and Mike's going to go over these and give you some tangible examples of how we do this. And then the last one are some of the proprioceptive exercises. Remember how you know where your ankle is in space. So what is a good stepwise approach for a return to activity? This is the most important. When can I go back to doing what I like to do? First, you got to be able to first walk without pain before you can start likely running without pain. And then once you can run in a straight line, pain-free, I tell people, then you have to be able to start doing laterals. So I tell them to run in a figure of 8, start doing that, run in a straight line, then run in a circle, then run in a straight line, then run in a circle, because you're slowly getting up the strength of those ligaments again. So the hardest thing to get people and patients to really embrace is this is such a pain, because you feel like, man, my ankle's not swollen, it feels pretty good, I'm ready, I want to go back out there and play soccer, I want to get back, back on my snowboard doing stuff. But if you shortchange yourself on rehab, you have a huge propensity to be right back in my office about a year later with another ankle injury. So the whole concept of return to sports or return to activities that you like to do is really a interaction between the person who's helping to treat you, your therapist, or if you're in a school where there's an athletic trainer. It's really important to have everybody on board of what your goals are and to make sure you don't go back too soon. So if you need some help with bracing, if you need a few more exercises to strengthen those lateral ligaments, then that's what the therapists are there to help you do. And this is the most commonly skipped step, but it's really the most important. So in summary, most ankle sprains can be treated with functional rehab. You don't need surgery. You very rarely ever need a cast or anything. Most of the time I put people in just a nice rigid brace on the side. They wear that for several weeks, then they transition out of that into something softer. But the only way to really make sure that you don't get into a constant cycle of re-injury is rehabilitation. And I have to constantly, especially younger kids, talk them into this fact that it actually is going to work and they actually have to participate and respond in it because they just want to get right back in. And I'm impatient too, and I'm probably the worst offender. I was, running along the Charles when I was a resident in like December, slipped on the ice, sprained my ankle real bad. I was just so anxious to get back in, so a month later I'm doing the same thing again, never did the rehab, didn't follow my own advice, sprained my ankle again, and then I was out for like 6 months. So I believe it. So we're going to give Mike a chance now to demonstrate some of the basic steps of this whole concept, because we found when we did this before, people really appreciated seeing, well, how do you actually do these exercises? And before he does it, does anybody have any basic questions about ankle injuries, sprains, fractures?